As I mentioned, Dr. Laura Corio is the author of the book, The Change Before the Change, which, by the way, is out on the Book Nook. I'm sure she'll be available afterward to sign your book if you'd like to purchase one. Dr. Corio is an OBGYN whose New York City practice attracts women from across the country because of her blend of no-nonsense medical advice, knowledge, and alternative approaches, and close collaboration with patients. She is a menopausal expert with over 30 years of experience. And she is, of course, the author of Change Before the Change. Okay, please help me welcome Dr. Corio.
Okay, I'm on? Okay, first of all, this is my first expo, and I have to say it is amazing what you guys have going on here. It's fantastic. I'm not serving food, I'm not doing aerobics, but all of the things that they have had before me are so important for us to go through a good perimenopause, menopause. So perimenopause is a normal, natural transition that every woman will go through. It can start as early as age 35 and go as late as age 55. And on the average, it occurs around age 46, with the average age of menopause being 51, and is a period in your life marked by the greatest hormonal shifts. It can start 4 to 7 years prior to menopause, and during this transition, you can have few symptoms or you can have many symptoms. And losing your period is the last sign of perimenopause. The diagnosis cannot always be based on blood or saliva tests. It really is based on symptoms. So when a patient comes to see me, I may send off blood work, but that's not the end all and be all. I still go by what the patient is undergoing. Noteworthy, menopause is a health milestone. It's a noteworthy signal of a new phase in a woman's life. It's the end of the female reproductive phase, and it's an opportunity for us to reassess our health status and our health goals. The demographics of menopause: 6,000 women in the United States reach menopause every single day, over 2 million per year. And today, a woman's life expectancy in the United States is estimated at 80.5 years. So perimenopause and menopausal signs and symptoms. What are some of the classic symptoms? The first sign is always a change in your menstrual cycle. That's the first sign of perimenopause. And along with it, you can have vasomotor symptoms such as hot flashes, night sweats, vulvovaginal symptoms, pain on intercourse, sleep disturbances, cognitive changes, memory glitches, your concentration changes. You can have physiologic symptoms such as depression, anxiety, moodiness, and there's no one universal menopausal syndrome. Okay, some of the talk today will be based on signs and symptoms, fertility changes, the relationship with long-term health conditions such as bones and heart and breast and colon and thyroid and reproductive organs, and lastly, how to have a healthy and happy transition into menopause. So the first sign of perimenopause is the change in your menstrual cycle. So your cycles become irregular. 90% of women have regular periods until they hit 40, but only 10% have regular cycles until age 50. Perimenopausal women have the highest rate of irregular periods except for teenagers. And as the hormones estrogen, progesterone, and testosterone decline, periods can become irregular. So from regular periods to the cessation of menses, some women will have infrequent lighter spotting, about 70% of women, the majority. 12% can just stop abruptly. But the 18% that have less than 21 days between their periods, or they're heavy or they're longer flow, those are the patients we're concerned about. So the bleeding changes, like I said, they can be lighter, they can be heavier, your cycle can become shorter, it can become longer, and once you skip more than 60 days, that can be a sign of late perimenopause. I give my patients a menstrual record chart to keep. I find it very good for them to document their periods. Today, there's so many apps that you can get on your phone to track your period. It's really important when you're going through this change and you're having irregular cycles to really keep a good record. And it's really easy now. It's funny, the young kids come in and they all have apps. When was your last period? They pull out their phone. It's just such a different generation. But the older women need to keep a record until they really stop their periods. So when you have irregular cycles, you could be pregnant, you could be on certain medications that may be affecting your period, hormones, IUDs, you could have liver problems, thyroid problems, blood dyscrasias, adrenal problems, or you could even have something with the uterus where you might have a fibroid or a polyp or even uterine cancer. So as I said before, you can have mild irregular periods and that can be okay. But the woman who has the abnormal uterine bleeding, where she has excess bleeding or intermenstrual bleeding, an etiology must be determined to distinguish, is there something wrong? What do I mean by that? When I talk to my patients, I say, my rule of thumb is that any woman over the age of 35 who has any change in her bleeding pattern, starts bleeding less than 3 weeks apart, or bleeding is heavier or longer, I want a phone call. And so we talk about abnormal uterine bleeding, bleeding after sex, or bleeding anytime during the period, or having heavier bleeding. And also, most importantly, if you go more than a full year without a period, you should never bleed again. And we talked about the first cause may be hormonal, where you're not making enough progesterone or you're making too much estrogen. You could have a pregnancy, you could have adenomyosis, endometriosis, endometritis, fibroids, polyps, pelvic inflammatory disease, infections, or uterine or even cervical cancer. And then there are systemic causes, such as bleeding, a coagulation problem, or hyperprolactinemia, liver disease, thyroid disease, obesity, anorexia, rapid weight fluctuation, chronic illnesses. Other causes could be taking steroids or taking a progestin or being on hormone replacement therapy or even hormones like oral contraceptives, anticoagulants, tamoxifen, and there are many herbs that can cause bleeding. I always do a history and physical. I always send off a blood count and a thyroid test. The patient may need a uterine biopsy, she may need a uterine sonogram, and she may even need to have a D&C or sonohistogram or hysteroscopy. So there's something called measuring the lining of the uterus on ultrasound. We call it the endometrial lining. And they say in perimenopause it's not so valuable, and in premenopause it's not so valuable because the lining changes with all the hormones fluctuating. However, in a postmenopausal woman, I will talk about that in a minute, it's a very good test. But if a patient is perimenopausal and she's having abnormal bleeding, one of the first lines of treatment may be to do a biopsy of her uterine lining. And it can be done very easily in the office without any anesthesia. It takes about 15 seconds. The younger woman who may have unopposed estrogen, such as obesity or polycystic ovaries, or persistent abnormal bleeding, she may need a biopsy. And it's very accurate, especially when uterine cancer occupies more than 50% of the surface area of the uterine cavity, and a positive test is more accurate for ruling in disease than a negative test to rule out disease. So, depending on your treatment would depend on what the cause is for abnormal uterine bleeding. But in a perimenopausal woman, birth control pills is a great way to go if she can take them, and it will make her periods more regular. We give progestins, we give Provera, we give oral micronized progesterone. We may be cycling it or giving it continuously. We use Mirena IUDs or Skyla IUDs, which have progestin in them. We might have to use surgery. We may use a GnRH agonist, which is not that common anymore. And tranexamic acid is an antifibrolytic, so it stops clotting, it stops bleeding and makes clots. Okay, so postmenopausally, now I told you if you go more than a year without a period, you really should never bleed again. And I always tell my patients, if you see any bleeding after menopause, please call me immediately. It could be coming from the vulvar area or even the urethral area where your bladder is. It could be coming from the cervix or the vagina. Could be from the uterus, fibroids, polyps, or cancer. Could be from the rectum. And if you're on hormone replacement therapy, it may even be that it's from hormones. So again, I said evaluating the postmenopausal bleeding, we begin with that ultrasound to measure the thickness of the lining, because the lining should be under 4 millimeters. And if it isn't, then we need to go forward and say, is it a polyp? Is it a fibroid? Could it be cancer? We may have to put some saline into your uterus and see, is the lining really thickened? And if it is thickened, you may need surgery such as a hysteroscopy to remove a polyp or do a DNC. Okay, here we go. Perimenopausal symptoms, my favorite. Hot flashes, night sweats, palpitations, mood swings, depression, insomnia, fatigue, memory glitches, migraines, joint pain, weight gain, vaginal dryness, and decreased libido. Doesn't that sound great? So 80% of women can have hot flashes and night sweats, and it can happen between ages 40 and 50. As many as 75% of women can experience them as early as 5 years before menopause. And the symptoms can get worse in late perimenopause, like I told you, when you go more than 60 days without a period, and early menopause. Okay, by definition, recurrent transient episodes of flushing accompanied by a sensation of warmth to intense heat on the upper body and face and head, commonly referred as hot flashes by day and night sweats by night, and they can sometimes involve the entire body, the elbows, the back of the knees. They can happen, 75% of people who are in perimenopause can have them. They can vary in episodes during the day. There can be few, there can be many. And the highest occurrence occurs during this perimenopause and the first year, 2 years after menopause. They can be intense. Some women, it can be severe, up to 10 to 15% of women. Some will abate after 3 to 5 years, but I've seen patients have them up into their 70s, and they can be more severe if you're a smoker. So there's a brain-body connection where, as your estrogen declines, hypothalamic, which is the upper part of your brain, there's noradrenaline, there's serotonin, there's dopamine, and there's acetylcholine. And so with the rise in norepinephrine or noradrenaline, you see hot flashes and night sweats and palpitations. But when the serotonin and dopamine decrease, you can have the mood swings and the depression and the insomnia and the fatigue. And when the acetylcholine decreases, you can have memory glitches. It's not really understood completely, the physiologic mechanism. It relates to small fluctuations in the core body temperature, superimposed on an extremely narrow thermoneutral zone. It can be triggered when the core temperature rises above a certain level and you sweat, and if it goes below, you would shiver. And factors that contribute to hot flashes. So warm environments, drinking hot drinks or spicy food, or having stress, or being heavy, cigarette smoking and alcohol can make all your hot flashes worse. Certain drugs, such as selective estrogen receptor modulators like Avista or tamoxifen, SSRIs that are antidepressants, and aromatase inhibitors that we use for breast cancer. You want to always rule out thyroid disease and infection and leukemia, pancreatic tumors, autoimmune disorders, and anxiety, because they may also cause hot flashes. And it's not that level of estrogen that's predictable. It's more the fluctuation that is the cause of having hot flashes. And treatment is based on the symptoms, the severity of them, what the woman's risk factors are, and her personal preferences. There are many forms of hormone replacement therapy available, and there's also complementary medicine, such as dietary supplements and herbs and other alternatives. Palpitation could last a few seconds to all day long. It could wake you up from your sleep. It's not a serious problem, but if you continue to have them, I would call the cardiologist and make sure nothing else is going on. Mood swings, depression, insomnia, and fatigue, they are all closely linked. Mood swings and depression will lessen after menopause. Unfortunately, insomnia and fatigue can continue and possibly worsen postmenopausally. Indeed, 3 years postmenopausal, 45% women are still affected. Memory glitches. So memory problems can be remembering names, remembering words, being forgetful. And the good news is the symptoms due to perimenopause will lessen postmenopausally. And then, of course, you have to worry, could it be Alzheimer's or is it just aging? Okay, cognitive changes. There is evidence that psychomotor speed and to a lesser extent verbal memory can decline slightly in perimenopause. Although depression and anxiety are related to cognitive decline, neither mood nor age account for the cognitive changes experienced by some women. Any transient issue with cognition appears to resolve after menopause. People have dementia and cognitive impairment, but not everyone with cognitive impairment has dementia. Dementia represents a decline in your memory and at least one other cognitive domain. The decline interferes with occupational and or social functioning. So you have to differentiate. This could be just your perimenopause, and once you go through menopause, things will settle down and you'll feel like yourself again. But if things don't seem to settle down, you may have to look and see if there's anything else going on. And you know, stress can definitely be a reason to make patients be forgetful, be on overload, be tired. So just normal aging, loss of fertility, sleep problems, medical problems, divorce or widowhood, an empty nest syndrome, sandwiched between the care of both your children and the grandparents, or career issues. And then the mood disorders, the feeling of being upset or loss of control or irritable or fatigue or blue moods at midlife may be caused by fluctuating hormones that perturb neural systems transiently, like that chart I showed you. Women with a history of PMS, significant stress, sexual dysfunction, physical inactivity, or hot flashes are vulnerable to depressive symptoms. And the most predictive factor for depression at midlife and beyond is a prior history of clinical depression. Relaxation and stress reduction techniques, counseling, psychotherapy, antidepressants are options to consider if symptoms are for management. Some women may have an increased vulnerability at a time of menopause. Women with anxiety or clinical depression may experience exacerbation during their perimenopause. It's unclear how schizophrenia or bipolar illnesses are affected by perimenopause, and a history of depression associated with cardiovascular disease risk. Now, sleeplessness. Both men and women report an increase in sleep disturbance at midlife. A higher percentage of women than men report sleep disturbances at all ages. About 46% of U.S. women age 40 to 54 and 48% between 55 to 64 report sleep problems. So that from 40 to 64 can have sleep problems. And the sleep disturbances are associated with fatigue, irritability, chronic illness, mood disorders. You can have night sweats that are typically occur the first half of the night. Advancing age can cause you to do early wakening. Sleep disorders, 53% have sleep apnea or restless legs or both. You could have depression, you could have pain, arthritis that might keep you up at night. Other conditions, cardiovascular disease, allergies, and some medications like thyroid medications may make it hard for you to sleep. So the treatment depends on your behavior, the drug therapy, or both. So some patients might have acute or a chronic onset, might be primary or secondary to other conditions. It could be related to your distressing vasomotor symptoms or just life stress in general. And so that has to be figured out. But again, as you know, sleep hygiene helps, and everybody talks about use a cool, dark, quiet room, use your bedroom only for sleep and sexual activities, use lightweight sleepwear, avoid heavy evening meals, avoid alcohol, caffeine, nicotine, chocolate, try to exercise but not so close to bedtime, use relaxation techniques. It seems like yoga and acupuncture help, and have a regular sleep schedule even on weekends. Now, hormone replacement therapy has never been approved to treat insomnia, but oral estrogen has been shown to improve nighttime restlessness, and awakening. Both estrogen therapy and estrogen progestin therapy appear to aid sleep quality by reducing hot flashes and night sweats. And micronized progesterone, which is the preferred progestin to take with hormone replacement therapy at bedtime has been associated with improved sleep. Now, headaches is very interesting because the abrupt decrease in estradiol, so women who have high estrogen then drops, high estrogen then drops, that can increase your risk for menstrual migraines and perimenopausal migraines. And the prevalence or intensity of headaches often increases, especially in women with a history of already menstrual headaches. And the frequency of headaches will decrease postmenopausally. And you can see the chart where between ages 40 to 49, there is a very high rate of migraines, and it slowly rises and it slowly decreases over menopause. It's linked between increased rates of migraines and perimenopause. It's accepted by neurologists now. I remember very early on, the neurologists didn't know what I was talking about when I was putting patients on estrogen patches, but now it seems very well known that estrogen is interlocked with this whole thing with migraines in your perimenopause. Hormone therapy is shown to exacerbate migraines in some women while easing them in other, but I think if you give continuous estrogen in a patch, they do so much better. Joint pain just keeps getting worse. We know that you can get arthritis as you age, osteoarthritis, rheumatoid arthritis, but it can get worse in your perimenopause and then continue. As far as weight gain, so this is a thing that we talk about all day long in my office, the percentage of population overweight in the US. Between ages 45 to 55, there's a frightening statistic that says a woman can put on anywhere from 10 to 20 pounds. And 70% of women between ages 55 to 75 and 65% of women between 45 and 55 are overweight, and approximately 40% are obese. And to add to insult, we lose muscle mass, we lose estrogen and progesterone, the stuff that keeps our weight down, and at the same time, our levels of male hormone, testosterone, insulin, cortisol can increase, and that makes you fat. Weight gain during this period distributes around our middle. So perimenopausal women, 80% of them have a waistline like a pear, but postmenopausally, about 40% of them have a waistline like an apple. So they have a bigger waistline. And the apple shape is associated with increased health risks: heart disease, diabetes, stroke, cancer, metabolic syndrome. Okay, now I'm going to go and talk about sex and vaginal dryness. So this begins in perimenopause and gets worse with menopause and aging. It is affected by the declining hormone levels, especially estrogen. And these symptoms can include vaginal dryness, itching, burning, painful intercourse, and there's an increased risk of vaginal and urinary tract infections. Okay, so decreased libido. Sexual problems increase with menopause, with 88% of women experience some type of sexual dysfunction in their postmenopausal years. And that includes a decreased interest in sex by one or both partners, decreased frequency, and pain during intercourse. Libido generally decreases with age. There's distressing sexual problems, peak during midlife, between 45 and 64, and are lowest from age 65 onward. Decreasing estrogen can result in the loss of vaginal moisture and elasticity, and a decline in androgens or testosterone may contribute to a decline in sexual desire, arousal, and vaginal lubrication. Vaginal sexual activity and lubricants may help keep vaginal tissues more moist and elastic. The effects of perimenopause on parameters of sexual functioning. Importance of sexuality remains constant. Sexual desire can decline, pain with intercourse can increase, and the frequency of sexual activity remains relatively constant despite reports of dryness and discomfort. Many women report that they're disappointed, that they no longer desire to initiate sexual activity. They sense the loss with their decreased desire, responsiveness, and sexual pleasure. The loss of sexual well-being can lead to depression, dissatisfaction with home life, dissatisfaction with emotional and physical relationship with sexual partner, and the relationship discord and stress. So you can see here in this chart that they talk about sexual problems and they talk about estrogen and sexual pain. And when your estrogen is low, there's an increased vaginal dryness, increased pain on intercourse, and there's also problems with intensity and penetration and burning. Estrogen is your critical factor in sexual desire and mood. Decrease as women age and go through menopause. So the first thing more than anything is I always try to replace estrogen vaginally. Testosterone is a critical factor in sexual fantasies and intensity of orgasms. It can fluctuate from perimenopause on, and it can be the fluctuation that's more important than the decline. Hormone replacement therapy effects on sexual function. It may not improve sexual desire unless vaginal dryness, dyspareunia, which is pain on intercourse, or bothersome hot flashes are part of the problem. It will improve sleep. It will help decrease fatigue. It can enhance the skin sensation and increase vaginal lubrication and elasticity. Testosterone therapy, it may increase sexual desire, arousal, and orgasm, may increase the bone density, may increase sense of well-being, but unfortunately there is no testosterone therapy that is approved in the United States. We end up using compounding pharmacies and compounding testosterone. Vulvovaginal changes at menopause, a loss of estrogen, and possible inflammation and tissue changes in the vaginal microbe, increased vaginal pH and an acidic environment to an alkaline one. Research has now found that some beneficial microbial communities are associated with higher pH. The question is still wondering if menopausal vaginal health is really normal or abnormal. And the symptoms, again, vaginal dryness, irritation, itching, dyspareunia, they can experience as much as 10 to 40% of postmenopausal women. I think that statistic is low. I think it's higher. Using vasomotor, unlike vasomotor symptoms, which will abate over time, like hot flashes and night sweats, the vaginal atrophy keeps progressing and it is unlikely to resolve on its own. And treatments include sexual activity, lubricants, moisturizers, local vaginal estrogen. Regular sexual activity helps promote blood flow to the genital area. Water-based vaginal lubricants and moisturizers help lubricate the area. Masturbation or use of a vibrator to maximize stimulation, and cleansing with water, but not soap or other products. Hormonal therapy, estrogen has been proven to restore vaginal blood flow, decrease pH, improve thickness and elasticity of vulvovaginal tissue, and if vasomotor symptom relief or osteoporosis prevention is not required, we go with low-dose local estrogen to the vagina. Urinary complaints are common in women throughout their life. Incontinence is the most common. Among 3,302 women, mean age 46, 57% had incontinence, and some of them had moderate or severe symptoms. Mild incontinence in early perimenopause tends to decline after menopause. And other conditions include frequency, urgency, dysuria, and rarely blood in the urine. I see so many women with urinary complaints every single day between the incontinence and the urgency and the feeling that they always have to go to the ladies' room. It's a big issue. We have to rule out a urinary tract infection, an overactive bladder, pelvic prolapse. Certain medications may be affecting your bladder and your bladder function. Atrophy, giving a patient estrogen vaginally could be the answer, or bladder disease such as IC, or even bladder cancer. So there are several medicines that are approved for overactive bladder. Kegels are really important. They can definitely help stress incontinence when performed regularly. Stress incontinence meaning that if you cough or sneeze, you lose your urine. And if you do Kegels, say 15, 3 times a day, the hardest thing is remembering, that really does make a big difference. I tell patients, do it in the cab, do it on the phone, do it when you're reading a book. Systemic hormone replacement therapy does not help. It increases incontinence. So that's not something that you would want to be on if you really don't need it, because it could increase your incontinence. Weight loss would help, and vaginal estrogen by far can improve urge incontinence, overactive bladder, and reduce the number of urinary tract infections. Okay, we're just going to say a few things about fertility. We know that our fertility peaks at 24. And that as a woman ages, her eggs, the quality can get poorer, her cycles can become irregular, and she can face a higher risk of miscarriage. The 24-year-old has a 10% of a miscarriage due to Downs, but a 45-year-old could have as high as a 53% chance of miscarry. And there's something called second or third day bloods in a woman's cycle, day 1 being the first day of your period, looking at your FSH, LH, and estradiol, especially in women over 35, to see if their egg quality is still good. Women decline in fertility. The fertility wanes in your 30s before perimenopausal signs even occur. By age 45, the risk of spontaneous miscarriage increases to 50%. The risk of having a child with congenital anomaly increases dramatically, and spontaneous pregnancy still is possible until 1 year after the final menstrual period. I always tell my patients you're supposed to use birth control up until 1 year after you finish your period because you can still get pregnant, and they look at me like, really? Okay, so now I want to talk about some long-term health issues that are affected once we go through menopause. We can look at our bones, we can look at our heart, our breasts, our reproductive organs, our colon, and our thyroid. They are all affected as we go through menopause. So the first thing is bones. Women reach their maximum bone density between 28 and 35. Osteoporosis affects more than 25 million women in the United States. 1 out of every 2 women in the United States are at risk for a fracture. Osteoporosis is the 4th leading cause of death in women, and it's preventable. This is what your bones look when they're normal, and then you can see what it looks like when you're osteoporotic. The disease is characterized by a low bone mass and microarchitectural deterioration of bone tissue leading to enhanced bone fragility and a consequent increase in fracture risk. Osteoporosis is the most common bone disorder affecting humans. The risk of hip fracture doubles for every 5 to 6 years increase in age from age 65 to 85. And of the 10 million American women estimated to have osteoporosis, 8 million are women. Postmenopausal osteoporosis. So if we peak our bone mass in some women between age 20 to 30, by 80, most women have lost 30% of their peak bone mass. Osteoporosis characterized by compressed bone strength, increasing risk of fracture. Some of the risk factors for our bone disease: being a white, female, and thin, smoking, having a family history of osteoporosis or fractures, thyroid disease, drinking more than 2 glasses of alcohol a day. My comment to everyone when they're drinking alcohol is 1 drink a day is good for your heart, but more than 1 drink is bad for your bones and your breast cancer risk. A sedentary lifestyle. Of course we want to exercise. We want to get out there and do some weight-bearing exercise, and we want to do some weights. We've looked at all of the stuff that's going on with the gymnasts and all the aerobic stuff and yoga, all good for you. Going through an early menopause or having a really long perimenopause. Vitamin D deficiency, if you were here before, they were talking about vitamin D deficiency affecting your bones, and too much caffeine. So the best way that we deal with osteoporosis is there's a FRAX, F-R-A-X, which is a tool that was designed by the Women's Health Initiative, which tells us our 10-year risk of fracture for a major osteoporotic fracture. And you plug in certain things, and I'll tell you in a second. It was instituted to measure and to show reduced modifiable risk factors through dietary and lifestyle changes, and if indicated, prescribe. Okay, so if we wanted to figure out if we're at risk, and then if we wanted to go on any medication. So FRAX, which is your risk of fracture for 10 years, age is important, sex is important, your height and weight is important, a previous fracture is important, a family history of a hip fracture, any secondary cause of osteoporosis, and having a low femoral neck bone density, which is where the hip goes into the pelvis. When we look at you, we do a history and physical. We assess your lifestyle behaviors. We review medications for the bones effects. We review calcium and vitamin intake, and we look at your height, your weight, any chronic back pain or kyphosis or clinical risk factors. We look at genetic factors because they account for 50 to 80% of the variance in the bone density. And we look at lifestyle factors such as nutrition and exercise that contribute to the rest. Now, when you do a bone densitometry scan on a woman, they really recommend it for women older than 65. However, I absolutely disagree. I think that women, once they start going through perimenopause and having changes in their periods and getting close to menopause, should all have a baseline bone density so we can see, did they make enough bone in their lifetime before they went through menopause, or do they have not enough bone to even start out with? And they talk about the FRAC score, that if the 10-year risk of major fracture is greater than 9.3, that they should get a bone density. Postmenopausal women with medical causes of bone loss and postmenopausal with history of a fracture, they definitely need a bone density. And it's just an x-ray. It's less than a chest x-ray. It's probably the easiest test that anybody could go through. They lay you down and they x-ray your hip, your spine, and your wrist. For postmenopausal women age 50 and older with one and more following, they also recommend a bone density if you've had a fracture, if you're very thin or your BMI is under 21, if your parents have had a fracture, if you're a current smoker, if you have rheumatoid arthritis, or if you have an excess alcohol intake. The DEXA is what we use, which is the bone densitometry scan. It's an x-ray, and we look at the total hip, the femoral neck of the hip, the lumbar spine, and the wrist. And as you can see, this is how we define it. Somebody who has a bone density, if they have a T-score of minus 1.0, they're fine. But if it's between minus 1.0 and minus 2.5, they have osteopenia, which is a low bone mass. And osteoporosis is when the T-score is under minus 2.5. And if you have osteoporosis, we're going to send off an x-ray of your back and your spine to see if you have any fractures. And you're going to be very concerned if somebody has a loss of their height greater than 20% because they may have fractures. Such as other secondary causes of osteoporosis, you could have hyperthyroidism, you could have a hypercalcinuria, which is high calcium in your urine. Certain drugs can cause bone loss, such as Nexium, calcium, vitamin D deficiency, rheumatoid arthritis, celiac disease, or other malabsorption diseases. And the most important thing for bones, like it's a preventable disease, but a lot of people don't really take charge and maintain a healthy weight or eat a balanced diet or get enough calcium and vitamin D. They talk about 1,200 milligrams of calcium throughout the day, preferably from food. So milk, cheese, yogurt, ice cream, broccoli. And vitamin D, we should all be taking vitamin D because in North America, there's no sun. So we don't get vitamin D. So they talk about 1,000 IUs. Everybody can have their vitamin D level checked. It should be between 30 and 50. You don't want it too low. You don't want it too high. We want to do exercise. We want to avoid excess alcohol. We don't want to smoke. And we want to also do some balancing techniques so that we will not fall. When is a drug therapy needed? The history of a vertebral hip fragility or low trauma fracture, you should really be on medication. If your bone density is showing osteoporosis less than 2.5, or if your FRAC risk, your 10-year risk of a major osteoporotic fracture, and this is really interesting because now when we send our patients for bone density, the radiologist gives you the FRAC at the bottom of the report, and if the fracture risk is greater than 20%, or if the hip fracture is greater than 3%, those patients should be flagged for treatment. And selecting a specific therapy is always difficult, and there's such bad press out there about all the drugs for bone density. And I have to say, I'm reluctant to treat people, but if I have to, I really try to counsel them that it's better to be on something than not. And the selection of one therapy over another cannot be made on a basis of clinical evidence. There's no head-to-head trials. The decision is really individualized, and there's various side effects, and there's regimens that you have to follow. The adherence to therapy is really poor, and the risks have been reported with long-term use of therapy. So something like Fosamax or Actonol, Boniva, you may be on it just a few years and then take a honeymoon because it seems that it stays in your bones for 10 years or more. Approved treatment options, so I just told you, biphosphonates. You can be Fosamax, Actonil, Boniva. There can be something called Avista. There can be something called Prolia. There can be Forteo. And they say combining agents is not recommended. Okay, now we're going to talk about heart disease. It seems that the number one cause of death in a woman is heart disease, which is always fascinating because if you ask a group of people, they'll never say that heart disease is the number one death in women. It's much more than cancer. 2.5 times greater risk for women than men. 1 in 9 women between the ages of 45 and 64 will have some form of cardiovascular disease, and 50% of women die of heart disease or stroke, and women have different symptoms than men, consequently less likely to be screened for cardiovascular disease. Cardiovascular disease will impact 515,000 women each year. It claims more female lives than any form of cancer combined. 64% of women will die suddenly of cardiovascular disease that have no previous symptoms. And heart disease death rates in younger women are now increasing for the first time in 4 decades because of diabetes, obesity, hypertension, metabolic disorders. The symptoms in women could be different than those in men. Angina could be mistaken for indigestion or heartburn. Women can have milder symptoms. They can have no chest pain. They can just feel weak or short of breath. They could start vomiting. They could have unusual back pain or body aches. This is known as the ABCs for a heart attack, and they may go better with a man than a woman, but it's angina and breathlessness, clammy perspiration, dizziness, edema, fluttering, gastric upset, or a heaviness in your chest. Now, getting to the heart of estrogen, what does estrogen do? Why do we do so much better when we're not perimenopausal or menopausal? Because estrogen helps our heart. It has a direct effect on our blood vessels. It dilates them. It decreases your blood pressure. So all of a sudden, in menopause, women start seeing that their lipids change, that they're getting higher bad guys, the LDLs, and lower HDLs because estrogen would have raised their LDLs. They may be all of a sudden having high blood pressure. And as in perimenopause, as estrogen declines, you see a drop in your HDLs and a rise in the bad guys. Some of the risk factors for heart disease, obviously menopause, genetics, your family history, your age, high blood pressure, diabetes, increased lipids, a sedentary lifestyle, obesity more than 25 pounds can increase your risk of a heart attack by 80%, smoking, drinking, and eating saturated fat. So what can you do to change things? Well, you can definitely stop smoking. You could try to thin down, try to lose some weight, get up and exercise, try to work with the stress, maybe yoga, acupuncture. You treat the hypertension, you treat the high lipids, you make sure you're not diabetic, and if you are, you get on the right drugs for diabetes. You want to change your diet from being high in saturated fats to a diet of poly and mono unsaturated fats. You want to watch the alcohol, and you want to see someone if you're undergoing depression, because that's not a good risk factor. So some of the things you can't change if you're aging, if you're over 55. You can't change if your dad had a heart attack before 55 or your mom before 65. You can't change if you have high cholesterol and high triglycerides, which are really very important. You have to lower them, but you may not be able to change them without going on medication or changing lifestyle. And the age at menopause, we go through menopause when it is determined genetically, and it can be very complex because some risk factors for cardiovascular disease may lead to earlier menopause. Do I have to stop?
No, you have extra time.
How much time? Because I'm not going to be able to get through them at all.
About 5 more minutes, and then we should.
Oh, okay. Then I want to go to the last part. I'm sorry, guys. It's all in my book.
And your book is here.
Okay, let me just go to the last part then. I knew it was going to be too long. Okay, so let's talk a little bit of non-hormonal treatments for perimenopause and menopause. So there are some antidepressants, but there's now a drug on the market called Brisdel, which is Paxil, which is now using for hot flashes and night sweats. There's other choices here. We're talking about Lunesta, which is a medication that women take to sleep, gabapentin, which is an anticonvulsant, and an antihypertensive called clonidine and Lyrica. So some of the antidepressants, like I said, selective serotonin uptakes, Prozac, Paxil, Brisdel, Lexapro. Then there's some of the SNRIs, which are Effexor and Pristiq. Gabapentin, if a woman has breast cancer and she cannot take hormone replacement therapy, or someone chooses not to use hormone replacement therapy for perimenopausal symptoms or menopausal symptoms, there is a drug called gabapentin, which I have given to patients, which is shown to decrease hot flashes. There is a medicine called Effexor, which has also been shown to decrease hot flashes. Lexapro has been shown to help sleep. In a randomized controlled study of 205 healthy perimenopausal and postmenopausal women with hot flashes, they found that Lexapro at 10 to 20 milligrams a day, compared with the placebo, could reduce insomnia and improve sleep. There's now a new product called Relazin, which comes from the bee pollen, which now we're using with women who even have breast cancer to decrease hot flashes and night sweats. Acupuncture has been shown, as well as black cohosh and topical progesterone. Eating a healthy diet, getting regular exercise, trying to avoid hot flash triggers, keeping the room cool, trying relaxation techniques such as yoga. Yoga, there was a 12-week yoga study that came out that showed helps sex, it helps sleep, and it helped hot flashes. Reduce sexual discomfort and increase sensitivity, moisturizers, lubricants, vibrators. How women view menopause. Midlife women do not consider menopause a time of health complaints, increased disease risk, or a time for medical care, but rather a natural, normal developmental phase. 51% in early postmenopause said they were happier and more fulfilled than in their 20s, 30s, and 40s. And about 75% of women surveyed reported making some kind of lifestyle change at menopause, and women with negative attitudes towards menopause report more menopausal symptoms. So we said having a healthy lifestyle, the tobacco, the alcohol, the drugs, trying to eat less fat, maintain caloric balance, consume whole grains, fruits, vegetables, water, take vitamins, especially calcium and D, and engage in regular physical activity. Most importantly, I want you to find a physician who listens to you and will work with you through the change. Be positive, take charge of yourself, keep moving. There's a light at the end of the change. Maturity, wisdom, and freedom to make your own choices. Thank you.
Great, Dr. Corio. I'm sure we must have.
Sorry, I couldn't give all the slides. It's
That's
just,
wonderful.
I would have been here another hour.
That's great. Well, there's so many things about menopause. Are there any questions? And Dr. Corio's book, The Change Before You Change, is also out in the Book Nook. We must have some questions about menopause.
Nobody.
Yeah, let me get up here. I'm going to use the mic so everybody hears you.
Okay. I'm going through menopause at the end of it, I believe. I'm going to be flying, and I'm going to be in Colorado at a high altitude. Do I have to be concerned about any changes? And I'm glad that I'm not crazy, that I don't sleep. And
Do you take any medication? Do you take any medication?
I do not.
Oh, then you have no worries. No, not at all. If you were on some medication that increased blood clotting, then I would say, you have to be concerned, but not at all.
Are there more questions? I've made a decision to not use any hormone replacement at all.
There's many choices out there.
Yeah, and I also don't use anything herbal because my pharmacist said that could be a time bomb because of my family history, too.
Okay.
So here's another question.
I've been on estrogen now for probably since 2000. At one point, they put me on a different patch, and it caused my head to go numb and my arms went numb. How safe is it, and how long can you be on it?
Well, there are slides on that, but I had a lot of slides. But what we first say is, when did you start it? Were you in perimenopause, menopause? Were you just changing your period when you started on the hormones?
No, I had a hysterectomy.
Oh, you had a hysterectomy. Okay, so you needed to be on hormones, which was really important. Okay, so my feeling about hormones is, if you're doing well on them and you've had no issues, and I don't care the length of time you've been on them, I look at it every time you come in and look at why you're on them and how you feel, and if you're feeling great on them and you're doing well on them, I don't have a time period where I tell you to go off of them. What I do is, as you get older, I will decrease the amount of hormones because you need less as you go further into your postmenopausal years. But the thinking of 3 to 5 years, get off of me, we're done, your benefits of your bones will get worse. your vaginal dryness will get worse. Your quality of life may get worse. So I'm very pro-hormone, especially if you're doing well on them. And you have to just make sure you're being screened. Get your mammograms, get your transvaginal sonograms. You know, just make sure somebody's watching you, and I would not pull you off of them so fast.
Now, the sonogram, I've never been offered one of them.
Right.
That's
Well, I
something
have to tell you, that's an interesting question because a lot of people don't do it. But I have to tell you, I swear by transvaginal sonograms where we look at the uterine lining. We've picked up early cancer of ovaries, early cancer of uterus. It is a wonderful thing to do. There was a what do they call them? Always these conferences that come out and make recommendations. And they basically said no one should have a transvaginal except you should talk to your doctor. And if you have bloating or you get full fast or you have urinary symptoms, oh, then you should have a transvaginal. Well, that's pretty much everybody in the room. So we recommend them, and we've picked up, I've saved more lives with uterine cancer and ovarian cancer because I do transvaginals. And if you're on hormones, you have to be looked at to make sure your uterine lining is staying thin. So you should talk to your doctor about a transvaginal sonogram.
Okay, thank
Yeah.
you.
Thank you. Any other questions?
Go ahead.
Right over here.
My mother had hot flashes until the day she died, and she was almost 70.
I know.
Just because my mother had it that way doesn't necessarily mean that I'll have it that way, but mine's are triggered by emotion, the weather.
Yep.
You know, if I get excited, happy, mad.
Right.
Yeah, I'm having one.
Well,
but I don't want. I like her. I don't do drugs.
Right.
But I was doing the herbal, but because of my health, I had to stop. But isn't there something?
Well, that study on yoga was very interesting. That came out of the North Menopausal Society that I'm a member of and credited. They showed that yoga really helps. If you did 12 weeks of yoga, it would decrease your hot flashes and help your sleep.
Yeah,
well,
if
you
you
know
have a
what?
bad back.
You have to sort of find someone who could work with you, maybe on a private, so that they could do the yoga without hurting you. But there may be some things that you could do that would help. Acupuncture as well could help you. If you don't want to take any herbals and you don't want to take any medications, then I really have to say the one thing that is nice, Relazan, which is new, a new product that came out of Scandinavia, which has absolutely been wonderful. It takes 12 weeks to work, but it's from the bee pollen, and it's even safe with women who've had breast cancer, and it's a really good choice that we have finally, that just came out a few years ago. It's called Relazan, Relizen. It's bee pollen.
Any other questions? Any other questions?
Thank you so much.
Thank you so much, Dr. Corio.